Great. Well, thanks, Mark, and thanks to the VBID Center for hosting today's webinar. We're just really excited to be able to share the experience that we've had so far with implementation of VBID in the state of Minnesota and with the State Employee Group Insurance Program. So I'm the research director at CGIP, and I'll get into my slides here. Okay, so a little bit of background on the State Employee Group Insurance Program. We're the largest group employer purchaser of healthcare in the state of Minnesota. We cover almost 130,000 covered lives, and primarily we cover our state employees, their dependents, separated workers who have access to COBRA, and early incentive retirees who are primarily in law enforcement and corrections. Notably, we don't cover traditional retirees. We have them in a separate pool, so we don't do as much coordination with Medicare as some other public employers have to do. We're a completely self-insured program, and we have 3 medical third-party administrators and 1 pharmacy benefit manager. And more than 8 in 10 state employees in Minnesota are represented by a labor union. And one of the things that makes CGIP a little bit different from some other large employers is that we operate a tiered network where we tier primary care systems across Minnesota at one of 4 different cost levels, and we've been doing this since 2002. And I believe we're one of the oldest tiered network systems in the United States. And notably, for the purposes of today's presentation, we cover about 6,000 adults who have diabetes. So we've been doing diabetes programming of various forms at CGIP for the last several years. We started out in 2013 with a medication therapy management program that had a big focus on providing pharmacist consults and those sorts of services to members who had multiple different types of medications, and then also discounting the out-of-pocket costs for diabetes medications, hypertension, and other related drugs. While this program was of great value to members who were enrolled in it, one of the challenges that we had with that old model is that only about 10% of our adults who had diabetes were actively enrolled in the program, many of whom had a hard time hearing about it or found some issues with getting enrolled or getting started in the program. And so that really helped to inform our program decisions going forward. And then in 2015, we implemented a new diabetes prevention program. It's an online program through our vendor, Omada. And for the last few years, we've been having more discussions with our labor union partners around the concept of value-based insurance design, and really trying to come up with the types of conditions that we should focus on, at least to get this implemented in the short run. And we ended up landing on diabetes, and for a few reasons that I'll get into in a minute. But the program that we ended up developing is called Advantage Value for Diabetes, and this launched on January 1st of this year. And it actually absorbed that old medication therapy management program. And that's where we started at today. So we don't have a lot of results to share. This is going to be mostly a story of our implementation process. So the reason that we ended up with diabetes in particular is that there's just a clear standard of care, and there's long established quality measures in the state of Minnesota. It's easier to measure the gaps in care compared to some other chronic conditions that we were considering. As I mentioned, we have 6,000 adults, so we have a large enough population to be able to run this program with, to understand its effectiveness. And that diabetes typically can develop early enough, and especially with a state employee population like ours who tend to stay with the state for a long term of service, that we feel like as an employer we can really make a difference in terms of their clinical outcomes. And so the way we landed with the program today is that the Advantage Value for Diabetes is for adults who are 18 and over with type 1 or type 2 diabetes. And as opposed to the old medication therapy management program, it's fully integrated into our main program, the Minnesota Advantage Health Plan, meaning that there's no separate enrollment requirement. Members automatically get this benefit just when they sign up for their regular health insurance coverage. The way the claims are administered is qualifying medical care needs to be paired with a diabetes diagnosis. And for the nerds out there, I included the ICD-10 codes if that's of interest. And for qualifying prescription drugs, they must also be paired with either having a medical diagnosis of diabetes or having a qualifying fill of anti-diabetic medication beforehand. So here's the actual benefit design that we ended up implementing for the AVD members. So as I mentioned at the top, we run a tiered network, and so our members are at one of 4 different cost levels. But because we steer members in this way to more cost-efficient clinics, 90% of our members are in clinics that are either at cost level 1 or cost level 2. So that's the top 2 rows here on this table. And for those members, they're paying really no out-of-pocket costs for the vast majority of their diabetes-related care. So for office visits that are related to their diabetes evaluation management, they're paying $0 copays. They're not paying any out-of-pocket costs, no coinsurance for related lab tests, and test strips are also at have no coinsurance as well. And some of the reasons that we ended up implementing some of these changes is that we really wanted to encourage members to have more access to these high-value medical services. We were coming from that MTM program that had emphasis on prescription drugs, so we wanted to build on that prescription drug program while also enhancing it with these medical services. And so on the office visit piece, I do want to mention that this includes both primary care and specialty care, including diabetic retinal eye exams and dietary consults. And on the office visit piece as well, you'll notice in cost levels 3 and 4 that we do maintain some copay amounts of $30 for cost level 3 and $50 for cost level 4 in order to continue to encourage members to go to those high-performing care systems. And on the prescription drug benefit side, we did something very similar where we're discounting across the board but maintaining some amount of out-of-pocket costs for preferred branded and non-preferred branded drugs. And notably, we're also including depression drugs as well as the diabetes, cholesterol, and hypertension drugs, which are traditionally part of VBID benefit designs, just because we saw enough co-occurrence between diabetes and depression that we thought adding in depression would help with the outcomes for our diabetes population as well. So when actually putting this benefit design together and getting it out to members, we really wanted to emphasize communication and really trying to drive people to make sure that they're getting the right information at the right time. So we launched a separate web page on our website that included links where people could get plain language descriptions of the benefit design. They could find the eligible drug list so that they could look up their medications to see if they were going to be covered under this program or not. We have a very detailed frequently asked question document, and then we also made it available for members to submit questions that we could use to develop our FAQs as we went along so that members were able to get all the detailed information that they really needed. And then along with that, there's the vendor communication piece, and it's having the right information for your vendors to be able to program out the benefit design and get that to work as you intend, and then also specifying all of the codes and drugs and how exactly you want them covered as well. So now that we have the program actually implemented, we are already thinking about next steps, and at the top of that list, and I hope Mark and Frank will really appreciate this, is an emphasis on evaluation and really thinking about what are we seeing in terms of outcomes from this program, or what are some of the things that we should be looking to keep an eye on over the next year or two as this program, as we get more experience under it and are able to understand its effects on our diabetes members. So when it comes to evaluation, we're looking at for the services, these high-value services that we've targeted, that we really have emphasized the reduced cost sharing for. Are we seeing improved use on those services? Are we seeing improved drug adherence for prescription drugs? Are reducing these adverse events that Frank talked about, the ED visits and admissions from diabetes complications? And overall, what are we seeing in terms of our cost trend? We really are, in terms of looking at the value of the program, looking at more of the member outcomes and the improved clinical care, but cost is always an important consideration for all employers. And then we're also looking at what other chronic conditions or populations could best be served by VBID under our program. Are there particular populations that maybe have more gaps in care that we think are amenable with a VBID style of implementation? And what are our opportunities to connect to provider quality? Minnesota is fortunate among some other states that we have some long-established quality measurement efforts, and one of the quality measures that's been around in Minnesota the longest has been looking at optimal diabetes care. And so we really do want to explore this relationship between for our diabetes members, are there ways that we can help steer them towards higher performing providers when it comes to the way that they treat their members with diabetes, their patients with diabetes, and make sure that they get the right care at the right time. So those are opportunities that we're really looking at for consideration in the future. But from our perspective as an employer, I think we do have some advice or considerations that we would want to share with other employers who may be thinking about implementing some other type of VBID implementation for diabetes. First is to really identify, what are the opportunities and the gaps and ways to boost adherence for your population. You should really look to your TPAs and your other vendors who are providing you data to see how your population compares to their benchmark populations, to see what gaps there are and what ways there are to do better, and how much of that can be alleviated by a VBID implementation. And how much do you want to discount cost sharing? Do you want to move towards $0 copays? Do you want to maintain some copay amounts? There's lots of considerations to think through with those ideas. And then the next bullet point really gets into, do you really want to design this all yourself? Unfortunately, we're a large enough office where we had the capacity to really be able to design the program here in-house, and then also rely on some other clinical experts who were able to give us some input. But we were really able to manage this implementation more internally. But if you don't have that capacity, you may need to look towards your carrier to develop a product, or maybe they have a pre-developed product that has a VBID design that you may look to purchase. With the enrollment process, do you want to do something more like what we did, which is more of an auto-enrollment model of just putting people directly into the plan? Or other employers, such as the state of Connecticut, had separate plans, separate VBID design plans that during open enrollment, their employees had the option of enrolling into. So that's another consideration. And then it's vendor integration, which is always among the most difficult tasks with getting a program like this up and going, is figuring out what are all of your vendors, your health plans, your PBM, the other parties involved, what are they all capable of doing programmatically with how they administer claims and making sure that the benefit design works as you want it to. And then are there opportunities to connect this program to your wellness offerings or things like that that can help kind of provide a more comprehensive program for employees. And then finally, our biggest consideration that we want to emphasize is that it's just critically important to communicate clearly to your employees, your vendors, your partners, whether it's the C-suite, whether it's labor leaders, so that they clearly understand what the intent of the program is, what the expected outcomes are, and what you're really trying to get out of an implementation like this for a program for diabetes. So with that wraps up my comments, and definitely look forward to any questions that we can cover. Thank you.